I want to dress up for y'all a little bit. I'm gonna undo this button though. Yeah. Well, good afternoon, everyone. Hopefully, you all had a great morning session, uh, and lunch was good. So I'm excited about that. Keep us up a little bit here. So we're going to do a little shift here. It's going to be kind of a Q&A between myself and Taz because Taz, you're great. Ha! We had a third party, but they're not here. But we're gonna pivot. We're gonna do what we need to do, right? All right. So I want to first introduce myself, and then I have Tess introduce herself, and then we'll jump right in to kind of like our questions, our 6 sets of questions, and um, Tess has some questions as well. So we're gonna kind of go back and forth, and then we'll have a moment for you all to do some Q&A as well. Okay? All right. So again, welcome everybody. My name is Ladora Yerkes Burnlow. I am the founder and executive director of Motivate Wellness Behavioral Relationship Health Services here in New Orleans. We have 2 locations, one here in Gretna, which is part of New Orleans, and Hammond, Louisiana. I've been in the mental health field for over 20 years now. As I say that, it's kind of like a shocker for myself, but definitely. I'm a licensed professional counselor. I'm a clinical sexologist as well as a clinical supervisor for new licensed therapists. And I'm a nationally board certified counselor. So take it away, Ted.
Yeah. Well, good afternoon, folks. Tasleen Van Hattem, you can also call me Taz. That's great. And by background, I'm what you call like a public health social worker. So I've worked in public health for about 20 years in my career, but I am a licensed clinical social worker. By background, I had the really distinct privilege of spending 7 years at the national level running the National Behavioral Health Network for Tobacco and Cancer Control that really focused at the intersection of tobacco and mental health. And that was both mental health, mental wellness, and addiction with a really strong focus on tobacco and cancer. And currently now I'm back home in Louisiana and sit as the interim director of the Louisiana Campaign for Tobacco-Free Living, which is a statewide tobacco control program in Louisiana, as well as the chief program officer at LPHI. Those are all really fancy introductions to say the 2 most important things to know about me in this space is I am a former smoker. And when I ever talk about lung cancer, tobacco use, and the intersections of mental health, I started using tobacco at 13. I spent 20 years smoking, and it wasn't until I was 33 that I was able to successfully quit smoking. It completely changes my own frame around both tobacco use, cancer risk, lung cancer risk, and the way in which people might experience that risk at any age. And then I think by way of introduction also that I have 3 aunts. I have my mother and 2 sisters, and every single one of them has been diagnosed with lung cancer. 2 have survived, 1 has not. And those devastating effects, I think, on my family have been something that's led me to really try to understand both the ways in which we individually deal with cancer and then the ways that we support families overall. So, and then the ways that we step into it each and every day with what that risk means for me and for my daughter as we think about what the future looks and feels like. So hopefully that gives you an idea of like why I would be here in addition to caring about mental health, Black health, and lung health overall.
Right. Yeah. That was a lot, but we got it.
It was a lot, but you know.
We got it.
Yeah.
So one thing that we want to do before we get into the questions, we want to acknowledge the room. Okay.
Yeah.
This is a safe place. This is where you can share, learn from us, hopefully, as well, and be able to deal with that, right? Mental health, today's focus, again, is about mental health and its impact emotionally as well, right? So we kind of look at that. So this is our safe space. This is our affirming space. And we want everyone to feel welcome for that, okay? So as we dive in, let's start with our first question. All right, so our first question is, when someone receives a lung cancer diagnosis, whether as a patient or a caregiver, what are the most common emotional responses you see, and what do people often not expect to feel?
It's like the big one. We're going right on in.
Diving right in.
I think like with any conversations about mental health and wellness, it's just like critically important to name the whole experience up front, right? That if you came into this room and if you leave this room, it's just with that one understanding that like a cancer diagnosis is never just physical, right? It's deeply impactful of one's family, one's faith, one's mental health, their sense of identity, their sense of community, and all those different pieces, right? And that we often just always lead with what's like the physical piece of a cancer diagnosis and really miss that piece. So I think, it's a very normal thing to see really increased anxiety, depression. I think for some folks, depending on when and how those diagnoses exist, it can also trigger some potential secondary traumatic reactions that folks might be carrying, et cetera. The normal things I think that we're all, and for in this room, many of you are likely even a greater expert than I am in terms of that lived experience and that layered experience of navigating this. But that shock, that disbelief, deep fear, I think is something that comes up. And then I think within that, what we really see is most particularly, which we talked about before folks came into the room, like where silence and withdrawal live in diagnosis. Really oftentimes rooted in not wanting to burden others, not wanting to burden family, children, and how that plays out oftentimes with individuals, but it also impacts caregivers and family units, parents or children, right, when there's a lack of information. And then I think in the context of other expectations, race, gender, we really see challenges around hyper-independence too, right?
Yes.
That you have a diagnosis and you're like, I got this, I'm gonna handle this, I'm not gonna burden others. So there's that like withdrawal as well. And so those are some, I think, the common ones that we see. I don't know,
Nervous about their village, right? And that's one of the things that we teach, especially when someone comes in with a diagnosis. Who is your support system? Let's make your village, right? It could be the smallest person in the room, right? It could be the oldest person in your family or even friends, right? That's your village. And sometimes people are afraid to reach out. And when they're afraid to reach out, that's that withdrawal that comes in there, right? And so one of the things that we do tell them is now they have to navigate that. They really, really have to navigate that and say, okay, how many do I need in my village? That's first, right? Because sometimes this can be overwhelming, right? But I can think of somebody from our church who had cancer several times. And immediately everybody was like, I'm going to help, right? But she felt overwhelmed. So what she was like, no, I need this person to take me to the doctor. I need that person to take me to the store, right? Those little things. So that kind of helped them. So being able to create your village is important. Yeah, I think that's the one thing that they missed, that emotional piece, for sure.
Share. It's like the most private moment that you have. Oftentimes, like we're really taught, particularly within, medicine, healthcare, et cetera. Like you keep, you're private about when you're going to your doctor, what you share. And we want that privacy within the sort of like medical care complex. And then suddenly, you're asked to, create a village and be deeply vulnerable about the things that, you've spent a lifetime being incredibly private about. And I think that's what we see a lot is folks being, it's, it's incredibly hard.
Definitely.
Yeah.
All right, so we're going to go to the next question. I think that you may have a little bit more information on this one. Okay. In the African American community, lung cancer can carry layers of stigma, right? Sometimes tied to the blame, as we said, the silence, and misinformation. How does that stigma impact mental health, and how can we begin to break that cycle?
Yeah. So, I mean, caveat with me answering this is like my expertise and the way I'm going to answer this is around shame and stigma around lung cancer. And I cannot speak, obviously, to the unique experience of being Black or African American and what that layers to it. But here's, I think, like where I know that plays out, particularly at the intersection of public health and then behavioral health, so mental health, which is that lung cancer has this unique weight and carries this really unique weight, stigma, and bias in the Black community because it's rooted in both the stigma, but also then the structural inequities that an individual and family experiences within both of those things. And I think, we're seeing that as stigma, we're seeing that as blame, and then we're seeing that as silence. Like it shows up really specifically. And I think lung cancer, the introduction that I give you is like, I don't give that introduction of myself for no reason. I give that introduction when I show up in a room because I want folks to know, like, I smoked and it's a risk. It's my personal behavior that led me to a risk that I am aware of. And I also give that example for folks to know that of the 3 women in my family that had lung cancer, none of them smoked, right? And it's incredibly important to live with both of those nuanced understandings, I think, right? That we often always assume that lung cancer is tied to assumptions about smoking. And sometimes it is. Like, I'm not trying to deny that that is a very strong reality and a deep risk. But it can also lead to a lot of like interpersonal judgment we have about each other, about personal behaviors, and then that's layered on already pre-existing assumptions about Black health and the way in which people make individual choices about their health, rather than recognizing the systemic structural inequities that they are faced with that also deeply impact that. Louisiana is a perfect place to have that conversation.
Absolutely.
We talk about this all the time about like lung cancer and tobacco use, but we live in Cancer Alley.
Right.
Our rates of environmental racism that deeply affect cancer rates and lung cancer rates are really significant. And so, yes, there's the individual behavior of tobacco use, which is not just a personal behavior when you talk about targeting and the way in which, the tobacco industry and, that the most legally addictive substance is, legal and continues to be. But I think that like Black patients specifically face that double burden of lung cancer, right? It's the historical and ongoing experience of being dismissed in care settings, not being believed in care settings too, that really plays out. And then that leads to, so like that's the stigma, right? The stigma around lung cancer, the blame that's faced around the personal, but then the historical and ongoing experience of being dismissed, I think that creates silence, right? When you don't trust somebody that, your care provider and so that's that layered, that people then can't share it widely and beyond.
Yeah.
So those are, but I would maybe even ask the same question back, because my understanding obviously is like not from and within the personal experience of also being Black and seeing how that, so mine is, I can talk about the structural pieces.
No, that's great. No, the structural piece is great, because I think one of the things that we missed is the structural piece.
Yeah.
Like, where does that come from, right? And you're working in the public health arena, so you're having that conversation where it needs to be had, versus for us on the therapist side of things, we have to shift that. We don't have that knowledge, right? We tell people to use their voice. That's the biggest thing. And some people don't know how to use their voice. So that's one of the things that we teach them, right? So when they're blaming themselves or blaming situations or saying like this, like you said, the doctor doesn't understand, right? Or the doctor's not hearing me. Use your voice. If for some reason that doctor is not hearing you, it's time to switch. Very simple. Time to switch. You have to be able to say, I will not be using you anymore, thank you. Right? And not feel guilty about it. Because that's the thing. But like, well, I've been with this doctor for 10 years. Right. Grandma used them. Right, absolutely. And so it's like, they should be good. Sometimes it's not for us, and then you have to look at it and say, okay, as I get older, as I, move on in life, there's cycles and levels, right? So in therapy, we try to teach that. Like, there's seasons in your life, right? There's that level. So when you need to switch up, you switch up. And it's okay to switch up and be okay. Yes.
Just a quick question, because I just wanted to clarify, I was not aware that there was a stigma in the Black community. So can you explain what?
Absolutely. The the stigma actually is a generational thing. It's kind of like a. Are you from New Orleans? Okay. All right. I'm gonna use New Orleans as an example, right? New Orleans had before Hurricane Katrina, we had what was known as our projects, right? That's a part of the stigma, live in the projects. So most of those that lived in the projects, they quote unquote said were poor people, poor blacks that couldn't afford it, right? And so what would they do? Go get cigarettes and all these things. So the stigma was just, we all gonna smoke together. So at like you said, you were 13.
Yeah.
Yeah. So that's the stigma. Being young, you start early. There's some that starts at age 9 and things like that, right? This is all you have. This project, right? So we're all gonna sit here and smoke together, right? That's that stigma. That's that for black people. This is what you have. We're gonna smoke. We're gonna drink. All of those things. And so if lung cancer comes up, they're shocked. What? What is this? Right? And it's something that's real. It's every day. You hear it, you see it on the news, right? Remember, the tobacco industry had to create the commercials, but also put the disclosure underneath it. Who reads that? Nobody.
Yeah.
Nobody. Yeah.
You come to me a third.
Yeah.
Listen, that lady had a question.
Yeah.
Sure. Sure. Come on.
Yeah. Yeah. Yeah.
Didn't just keep on bringing on, but anyway,
Mhm.
it was actually to piggyback on a topic
Yeah.
when she was talking about the and how like not people those are just about
Mhm.
asking how many people get vegan.
Yeah.
And sometimes they create this village, you create a village with people who you trust and that you can comply.
Yes.
And when you find that that trust has been breached,
Yeah.
it makes
Mm-hmm.
then you give them false truth. Then things like so yeah.
Yeah.
Absolutely.
The stigma is really
Yes.
low and not here there.
Absolutely. It's everywhere. Yeah. Yeah.
Yeah, I mean, I want to go to this gentleman, but I want to note like the stigma too that I was talking about is like we act and blame people for their tobacco use. And there is a stigma. Providers have it, people have it. Like you sort of brought this upon yourself because you smoked, right?
Which is
Like
the example
we
I gave
all
about
know.
the project.
Yeah, right?
And
Like that, yeah. Yeah,
Preceding question.
is smoke.
yes.
And so there's that stigma without realizing, like, Black communities have been heavily targeted and individuals with behavioral health conditions, right? Like we used to drop off, not we, but, the we used to drop off free cartons of cigarettes at psychiatric hospitals. Like, here you go. Like, right? So marketing, targeted campaigns, right? Selling more and with greater advertising in Black communities, products that are more appealing to Black youth, right? So all these things, while then, like I said, being able to legally enhance a product to be one of the most clinically addictive substances that we have known, that, and then continuing to further market that. So it's that structural piece, like the personal stigma is, I think, often what happens within many communities, but specifically the Black community, where then there's a personal choice and you're to blame for it. But the structural pieces that led to that personal choice are multi-generational, they're deeply rooted. And okay, I'm gonna go to this gentleman because he had his hand raised and then come over here. Yeah.
You made a thing about changing doctrine.
Yeah.
I tell you, to me, I'm a therapist, and so I have a deep-rooted problem with the primary that they don't take seriously when a person has a illness, like cancer. They know about it.
Yeah.
But when, like, my wife goes and sees her, and we changed. We got rid of her. And then we got rid of her.
Good.
But she just didn't focus on, she did the regular checkup and everything, but she never asked her, how are you doing?
Wow.
Was battling stage 4 lung cancer. I never heard that lady say one time, how are you doing? You know, and then when my wife would have, when she went to her clinical trial, that lady did nothing. She never even seen the person. She never even seen Cherie. It wasn't even, the thing that was going on with my wife was not even, had anything to do with a cancer. It had to do with her personal stuff.
Yeah. Yeah.
And I was just so frustrated, you know, so please, when you get an illness or diagnosis like that, and your primary doctor is, I'm not saying, don't get me wrong, she's not concerned, but she's not working with. Engage, whoever said that word. Yeah, engage. That's a good, you know,
Yeah.
we need them engaged.
Absolutely.
Because there's other things going on.
Absolutely.
I've had it told my wife many times. I don't feel she's good enough for you. I think we need to change. You know?
I love that. Yeah.
Yeah.
That's
So-
You know, having that voice,
Yeah.
and needing to say or express how you felt to have PCP, and once you to switch, it's actually what led me to my diagnosis.
Look at that.
For a very long time, for like 7 months.
Yeah.
Yeah.
Go on to see the specialist, communicate.
There you go.
Engaging with me,
Absolutely.
figure it out. But it just took me to the last point. I was like, you know what? I feel like y'all dancing around this. But why you feel like that? I said, one, truly, I'm black. Well,
Yep. Double jeopardy. That's what they call it.
must have said keyword to him. 2 days later, I had a diet biopsy. 2 days after that, I had a PET scan. And by Saturday, I was diagnosed with lung cancer. They have to fight for yourself.
You had to.
Yeah, and having that voice or getting that frustration built up inside of you, like you yourself want to find out what is wrong with you so you can help yourself.
Right.
Gives you enough courage to say you need to say those people.
Absolutely.
But my wife switched her primary doctor. She has a primary doctor at Stanford. They are knowledgeable. They ask her how she's doing. They already know what she has.
Yeah.
You know, and so she's aware. My wife goes back to her just a regular check. We go to Stanford. They fake appointments where she can see her primary doctor and
Good.
something she has to go through, and it's working together.
That came with intention. I brought about this in my book that I just published in 2020.
Woo.
That comes
Love
with
that.
that you must get them to collaborate by empowering them. I empowered each one with my records, with access, so that I can make sure that each of their services, for example, I'm at Stanford, I'm gonna tell you this, the personal care physician, okay, what are you here for? Why are you here today? Okay, fine. You didn't do the background. Let me address maybe some joint issues with me. Is it directly connected to the MBL 655 clinical trial or not? Not. So I have to weed them out. But technically, all of them should be helping me determine which one is a side effect.
Right.
Based on the trial protocol. I read everything. Right. Based on the protocol, you're supposed to be helping me identify what is part of the side effect of the MBL 655 clinical trial and what is not. But since you need me to help you do some of your work, I'm glad to do that. But I don't get paid your salary, but I do help them to really pinpoint areas of concern and pull them all together.
Right.
So here's what happened. So I needed some prescriptions. Well, I sent it to the oncologist. Oncologist said, well, that's not my area. Your physical physician needs to do that one. Okay, fine. I'll talk to the physical physician, which is on the same day because I'm queen at scheduling of mine.
Yeah.
To do this fun stuff myself. And I'm thankful for the quality of life.
Absolutely.
I said, you know what? My oncologist said that he's not responsible for this particular type of medication, so it's on you. So, what is the medication? So now I'm educating you again. What I need. I shouldn't have to do this, but I'm proactive. My husband is proactive.
Yeah.
We're a team. We're gonna come in like velociraptors.
That's it. That's it. I love it. That's it.
And I'm not gonna spend
Mm. Yeah.
okay, this is what I need, leaving for this, and then let's cross check that. Then I'll make them work.
Yeah.
You know, this is that medicine. Should I be taking it? If so,
Yeah. Advocating.
Well, I get to that point to say this. As a caregiver, you care for your loved one.
Yeah.
The best care, you know, and so if you have to move mountains,
that's all.
move it. That's right.
Love it.
Let-
Which brings us to our third question, but come on.
Gonna pivot on what everybody is saying. I'm a social worker and I work with hospice patient, and when she asked about what the systems are,
Mm-hmm.
to me in the African American community, not only I can say it's a lack of education, and then seeing the fact that we lack that education, we don't have the advocacy piece to know what to ask
Absolutely.
or reach out to, and then of course as social workers, that's our job to assist, but it only can go so far.
Right. Because we're limited to what we have, resource-wise. We are limited. Mm-hmm. But they keep forget that.
Thinking about how cigarettes or alcohol is on every corner. Working in facilities where we are taught this is all they have is food and cigarette time.
Mm-hmm.
You're using this as a behavioral modification to calm your patients. So when I go to other communities, not so much.
Yeah.
Ones are really heavily involved. They're more educated and they're not hesitant. They really advocate for that environment to be different than what you see in the inner city sector.
Absolutely. Absolutely. Well, our third question actually leads to you, sir. But we're going to answer it first and actually have you answer if you want to, right? So the third question is, caregivers are often expected to be strong. For everyone else, what are some signs that a caregiver is emotionally overwhelmed, even if they're not saying it out loud? What have you noticed?
I think you both of you pointed to like really powerful things within the caregiver experience. I think oftentimes the first way that we see caregivers show up and it's clear that they've passed a certain threshold of being able to hold that experience is in their own physical health. Right? Oftentimes they're not going to say, I have anticipatory grief about what might happen to my loved one, or I'm carrying depression and anxiety as a constant state myself, or, you know, I'm engaged in navigating systems while carrying everything else, or caring for a wife or a loved one in these ways. And oftentimes what happens is their own physical health, because they're holding it all in, they're holding it together, and we see that manifest in other ways where you're not able to care for yourself. So that's, I think, where where I have seen it the most common. And then for folks that are willing and able to talk about it, then you do know it's really within that larger grief space, the depression, the anxiety, and yeah, those would be some of the, I don't know, how have you seen it show up the most?
For me, most of it was just, as you said, the physical part is there, definitely, but it's the moments of silence, just sitting, right? And they're withdrawn from doing activities, or even just withdrawn from just people in general, like sitting there watching television, right? Favorite television shows on, but they're not even laughing at what's happening, right? If it's a comedy or something, whatever it is, you notice that change, right? And it's not that they're purposely withdrawn. They're still trying to process what all has just happened, what all is taking place, or if your partner is sick, right? To throw in all of those things, and they can't do anything but sit there and hold your hand. What do you need from me to do, right? Or as my husband said, what do you need, baby? Right? Y'all know I'm from New Orleans, right? That happens. But that is what that is, right? And even though he can't touch it or fix it for you, you feel helpless and hopeless, right? So they start to withdraw, and then when they got to step up, right? Like you said, the talking to the doctors and everything, they're in there. That's that strong pull kicked in, right? That's that adrenaline. But when you see them withdrawn, ask that question. You said perfectly earlier when you said she didn't even ask, how is she today, right? Caregivers need that same question. How are you today? People have to remember that. That is a question. That is a question that needs to be asked to everybody. Even when you're in the doctor's office and you want the doctor to ask, how are you today? That is what they need to say, but they need to also say it to the caregiver. Well, how are you? Right? Because then they can refer them out. Especially if they say, well, I'm not doing well. Or today is not a good day. If you say that, they should be like, okay, well, we'll see if we get you in a support group, right? For caregivers, support group for the cancer patients, right? Or just even talking to somebody individually. Sometimes that's important, but the doctor can say that, right? They should all say that. I think in our office, one of the questions we ask is, tell me how we feeling today. If my client comes in and they say, I'm okay, I say, okay, let's try this again. Because I heard so much in those little words that you just told me. So we tried again, right? And I said, let's take a deep breath. Now I'm going to ask the question again. How are we today? And this is even before we even get into session. Why? Because I need to assess what's happening with you. Because people don't ask that question. Yeah.
Yeah, I was going to say the freshmen, when we come into some appointments together, they look at me, and I don't know if this is a most women thing, or this seems to be standard now, which is, hi, Sharice, how are you? And then it just pulls this with you. It's a way of them, is he okay to be like checking for some kind of safety? That's just weird. They do it in the real study.
Okay.
And we got to ask those questions.
So just know that a lot of that's going on too.
Yeah.
Which is, okay, I'll have to satisfy that. Yes, this is my husband with this, and then I'll joke.
Yeah.
You know, I'm the one breaking the ice, not them.
Yeah.
I've been married 36 years. Yeah.
Right.
With me today.
Right.
You know.
I like him today.
My wife, after they took her off, elected work. Elected after my office trial, which she's doing very, very hard, baby. But before the doctor started off at the highest dose, it fell apart a little. We don't say whatever, she fell apart.
No, the hormones. Menopause, they threw me in menopause.
We feel it.
The caregiver, you don't know, like.
No, you don't.
You want to help, but how to help? And she's going up, she wasn't feeling well.
All of that.
I've never seen her, that bad. Thank God, thank God, I've never seen her that bad.
Yeah.
So, come out and just sat with her, really didn't say much. So I just prayed.
Yeah.
Sometimes you just go ready. You take it to a higher person higher than you.
There you go.
That's what I did. It worked for me. She's doing a lot better now, but we don't know exactly what's going on, so we don't exactly know. I advise, that's what I did. To keep my sanity and, don't worry and try to get some sleep and stuff like that. And just give it to somebody bigger than us. If you don't want to give it to somebody bigger than you, talk to somebody.
Yeah.
I recommend that because we just came out of that situation. And it was stressful.
Oh, yeah.
It was very stressful. She's doing better now, but it was a combination of hormones and stuff like that and the new medicine, and now she's right here. Thank God.
Troubleshoot that with NBL 605. She and I, what's her name? Crystal just met you today. Let me get your number. Crystal and I should, her medicine, some of these cancer medicines throws you into a hormone imbalance.
Wow.
So there is a hormone replacement therapy that you can explore if that happens to you during a cancer journey or a lung.
Okay. Yeah.
Well, it's also like just really powerful to hear you both talk about like how even in the clinical care, the role of the caregiver gets minimized too.
much so.
And that if you're there and you're there in constancy, the, provider also needs to recognize, let me be clear and have open communication with you, right? Like, be providing those additional supports that they might have for caregivers, right? And even in any clinical care setting, it can be incredibly minimizing. When you're there and it's clear that you're bringing the person along, and that's as important. So I think it's important to recognize within the caregiver experience too, even though you're like front and center, others will minimize that in the same way they minimize, where you sit and how you sit.
But I services to breathe. It changed me as a clinician. Rendering service to someone's loved one after they pass. This lady said to me, can you imagine the level of PTSD that I have? Watching my daughter died 15 years.
Yes.
And I was kind of blown away. So it does change you as a clinician to understand that they are a pivotal piece to the healing of your patient.
So very important. They're part of that village. Yeah.
That's why the caretaker repeat part. Like,
Absolutely.
That, I thought that they would be on something kind of all day with the caregiver.
not sure.
I'm not sure. I'm sorry.
No,
No?
it's okay. No.
But it's incredibly important to just keep highlighting, as you said, that role.
Right. We've got about 5 minutes, so we want to do one more question, and then we'll take some time for some Q&A. Okay. So I think we'll go down a little bit here. If you could shift one mindset or belief that patients and caregivers carry about mental health during this journey, what would that be?
We talked a little bit about this before y'all came in the room.
Right.
And my greatest, first of all, like as somebody who smoked for 20 years, I was like, I'm not interested in being in tobacco control. I have like no interest. I loved smoking. I was forced to quit for my health. Like, but I was like, this is something I enjoy. I'm addicted. I find it to be all these things, right? And I never wanted to be in tobacco control. It was just, it felt very rigid, very public healthy. It wasn't, and it wasn't until I actually was brought through the doorway of health equity to really understand why tobacco use is an equity issue that I became really deeply passionate about tobacco overall. And the real reason why is and so for me, it's like, it's lung cancer as the subsequent endpoint, but it is that prevention focus. And it's because the single greatest risk of tobacco use in our country is exposure to adverse childhood experiences or ACEs. So exposure to trauma is the single greatest predictor of early initiation of use, duration of use, amount of use, and adult use overall. And the definition of ACEs used to be individual, but that's like grown over time in the way we understand ACEs is also racism and the way that that's enacted, or community violence, poverty, incarceration, many of the larger equity issues. I mean, we have divorce and some of the other interpersonal child abuse and neglect. But all those things for me were so important. And they're important in this mental health conversation because it helped me understand that, we don't suddenly just show up at 40, 50, 60 with a lung cancer diagnosis. That's not how this happened, right? Like you have a greater risk either through environmental exposure or through tobacco use or through exposure to adverse childhood experiences that are very oftentimes not the things that you yourself have stepped into, and how that has increased your risk. And for me, it can be really empowering to know that, you don't end up somewhere just because of your own personal behaviors and that shame and that stigma. And that, like I said, a cancer diagnosis is never just physical. It's the mental health and it's the structural and these other pieces.
Exactly.
And that is, I feel like, what I wish people really understood about lung cancer, specifically.
Yeah. And I think for me, it would be simply to be able to recognize when you want or need help for someone to talk to. right? Advocate for yourself. Just like you were able to go to the doctor and say, hey, I need this done, right? You can also do that with your doctor. Say, hey, I think I need to talk to somebody. And they should be able to provide that services, right? Because as you mentioned, PTSD is real. All of you have it. You know, there's something that happens, and then at one moment it's quiet, and all of a sudden it hits you, right? And so it's something that is very, very important. So we have exactly 1 minute. We're sorry. 1 minute.
And I just want to add, for me, to shift in the mindset, you don't have to smoke to get
Correct. Absolutely. Correct.
and honestly, everybody I know does not
Wow. Yeah.
lesion has never smoked, ever lived their life.
Very important.
So that and age, I don't think that things that you have to get older, but there are young people
Yeah.
getting lung cancer. So those are
We look better in this light, anyways. We're good.
Yeah, we're good.
I believe a lot of health advocacy and things at my church, and if I went to one cancer, first they did say, oh, I'll smoke
Yeah. Yeah.
You don't like to.
Yeah.
here. And
It's like the man, it's just as dangerous as it with.
Absolutely.
I was exposed to it. You heard my voice here too. Really often smoke with a rope in. It was a cloud.
Yeah.
And by me being in there for a half an hour, I walked out that door, my hair, clothes, and everything is stuff.
Mm-hmm.
As if I smoked. So yeah, you don't have to. But secondhand smoke is just the same.
Well, we want to thank everybody for coming in and enjoying it. Just remember, we are here to help in any way that we can while we're here at the summit. But even after that, you all have our information. And please don't hesitate to come and ask us any questions, okay? Yeah. All right. Thank you all.
Thank you.
All right.